Hello, my name is Richard Schaffer and I'm a radiation oncologist and medical director of Xstrahl. On behalf of Xstrahl and our CEO, Adrian Treverton, I'd like to welcome you to today's educational event on radiotherapy for benign skin disorders. When I first started treating patients with radiotherapy for benign conditions, I found it hard to find reliable, clear and peer-reviewed evidence and practical information about how to deliver these treatments. Working closely with the session chair, we've designed this educational event to start to close that gap. We did hope there would be a lot of interest in this topic, but we've been overwhelmed by the amazing response, with more than 700 people registered for today's session. At the end of each talk, there will be a live Q&A with the panelists, moderated by my colleague Christian Moby from Xstrahl. With no further ado, I'll hand you over to today's session chair, Professor Reinhard Dummer, for some introductory comments. Thank you.
Thank you so much for this kind words. So also from my side, a very warm welcome to this symposium. I think it's a topic that is hardly reported on, and obviously the participation shows that there is a huge interest. And with this, I also want to thank Xstrahl for hosting this event. I think it's a very good initiative because many of us use irradiations for benign dermatosis, but there's not so much exchange ongoing, and therefore I also support the initiative to found a new society. And with this, I want to introduce the first speaker, who is Dr. Egle Ramelite. She is MD PhD and attending physician in our clinic and is involved in the irradiation unit. Egle, please, we are looking forward to your presentation. Enjoy.
Dear colleagues, dear ladies and gentlemen, my name is Egle Ramelite and I'm very happy to talk about radiotherapy in disseminated superficial actinic porokeratosis today. I want to thank again for the organizers of this amazing event for Xstrahl. So thank you very much for having me here and choosing my presentation. First, a quick overview about porokeratosis. Those are a group of uncommon acquired or hereditary dermatoses that occur due to increased proliferation of atypic keratinocytes that show faulty maturation and early apoptosis and dysregulation of differentiation. It is a keratinization disorder whose origin is still not clear. However, there are a few triggering factors that have been defined yet. For example, genetic, ultraviolet radiation, radiotherapy, immunosuppression, drugs or chemicals, or others. Clinically, the porokeratosis present as well-circumcised, slightly atrophic papules that can coalesce to a bigger lesions, and they usually show a plaque with a keratotic ridge. The middle side can be somewhat flatter. There are more than 5 subtypes of porokeratosis defined, which all show different clinical presentation. However, they all share a histopathological hallmark of cornoid lamella. Here you can see a few examples of different types of porokeratosis. On the left-hand side, you can see a patient with disseminated superficial actinic porokeratosis, widespread on the lower and upper legs. The second picture shows a patient with linear porokeratosis, the third one with porokeratosis mibelli, which appears usually on lower legs, and the fourth picture on the right-hand side showing porokeratosis ptucotropica that usually affects genitoanal area. Here you can see a histological figure of a porokeratosis, and what is typical, marked with blue arrows, is the cornoid lamella. On the with the green yellow labels, you can see the hypertrophic epidermis on the outside of the cornoid lamella and hypertrophic epidermis in the middle of the lamella. You can also see the inflammatory infiltrate on the ridges of the cornoid lamella. Upon closer view, you can see the dyskeratotic and vacuolated keratinocytes over here. This is the cornoid lamella, and some inflammatory infiltration around the blood vessels close to the lamella. The tumor suppressor protein p53 is known to be increased in malignant diseases, and indeed in porokeratosis it is also increased. However, this increase of protein is not related to a gene mutation, which is often seen in malignant diseases. Moreover, p53 is also increased in inflammatory diseases such as psoriasis when compared to healthy skin. And proliferation rate of cells in the porokeratosis is not increased, which all talks to favor of porokeratosis being a rather benign condition. However, malignant transformation was reported in 3 to over 10% of the patients with all types of porokeratosis. However, in psoriasis treated with UV light, be it PUVA or narrowband UVB, we also see development of skin malignancies in 5 to 12%. Porokeratosis are also often associated with actinic keratosis, another premalignant condition. And we can also see keratinocyte atypia in both porokeratosis and premalignant actinic keratosis. However, in actinic keratosis, the risk of malignancy is higher compared to porokeratosis and is about 10 to 20%. However, taken together, increased p53 expression with a low proliferation rate, where data is missing regarding the malignancy or entity of this disease. There are reports that state that large lesions, usually localized on the extremities, may transform into squamous cell carcinoma in the average of 36 years. However, how do we treat the most common type of porokeratosis, namely disseminated superficial actinic porokeratosis, or DCAP for short? It usually appears in quite early patients, quite young patients, 30 to 40 years old, and mostly on UV exposed areas, that is lower and upper extremities. It can seldom affect face or the back, and it consists of multiple small disseminated plaques with symmetrical distribution, meaning both arms or both legs. It tends to worsen and progress upon UV exposure, be it natural light in summer or narrowband or PUVA for treatment of other skin diseases, and it tends to improve in winter. Patients may not have any symptoms at all. However, up to a third of them complain of itch. But how does disseminated superficial actinic keratosis look in a clinical sense? Here you can see multiple erythematous lesions on the upper on the lower hand of the patient. And what is important here, we can see it on the sun-exposed side, but not on the less sun-exposed side of the hand. Here we can see the same distribution on the upper leg and also on the lower leg of a patient. However, the backside is somewhat less affected. So how is disseminated porokeratosis treated? A systematic review and a meta-analysis was reported in 2017, and you can see that most of the treatments that were investigated in DSAP were based on case reports, case series, and there's only one prospective multicenter pilot study that evaluated topical diclofenac in patients with DSAP. In this trial, patients received topical diclofenac sodium 3% gel twice daily, and the report said that patients developed partial response by DSAP lesions progressing to a lesser extent on the treated side compared to the global lesion count. However, multiple other treatments that are used for treatment of actinic keratosis, such as imiquimod or 5-FU, as well as laser treatments, phototherapy, have been investigated, and the responses range from no remarkable change to complete clearance, complete remission, and modest effect. So what we did at the University Hospital of Zurich, we reviewed our patients that were treated with Grenz rays for DSAP. We reviewed cases of more than 2,000 of patients, and we selected patients with a histological or clinical diagnosis of DSAP that were treated with radiotherapy and had a follow-up of no less than 4 weeks, and we could identify 8 patients. We evaluated the clinical parameters of DSAP, the concomitant cutaneous pre-malignancies and malignancies, the safety of the radiotherapy, and patient demographics. Here you can see an overview of our 8 patients. You can see that the patient age ranged from 54 was the youngest patients to 84 was the oldest patient. Most of the lesions presented on the legs and arms, and one patient also had some lesions distributed on the back. 7 out of 8 patients had other skin pre-malignancies or malignancies. 1 patient had melanoma, others had more of keratinocytic disorders such as actinic keratosis, Mervis Bowen, Bowen's carcinoma, or squamous cell carcinoma. And you can see that all but 1 patients were pre-treated with all the treatments that I just mentioned being seldomly effective. Here you can see the distribution of the lesions with red color marking the distribution. So least number of patients had DSAP on the upper arms, mostly on the lower arms and lower legs. You can also see the marked other pre-malignancies or malignancies. The most common was actinic keratosis, and you can see an overlap of actinic keratosis and DSAP, and also squamous cell carcinoma labeled with a star, or basal cell carcinoma labeled with a triangle. So those patients received treatment with Grant's rays with 10 kilovolt for 4 gray 8 to 10 times every 3 to 4 days. All patients were able to finish the treatment, in exception with 1 case which was stopped due to adverse events. And here you can see the total dose that the patient received that ranged from 29 in 1 case to 52 in another case. Some patients also received soft rays due to other malignancies, for mostly for Bowen's carcinoma that developed on the same site as DSAP. You can see that all patients developed an acute radiodermatitis, but this is also what we expect from patients treated with radiotherapy. And you can see that follow-up ranged from 2 months up to 65 months. Out of 8 treated patients, only 1 showed clinically suspected relapse after 46 months of follow-up. However, none of the other patients showed any relapse in the treated areas. Here I can show you an example of a patient that was treated for DSAP with Grant's radiotherapy. You can see the marked fields on the lower left leg of a patient, and this is already after treatment. You can see that there are only very few lesions left that disappeared later during follow-up, and here we can see we irradiated another site, and here you can also appreciate the post-radiotherapy hyperpigmentation. Another patient had her lesions irradiated on the lower left arm. Again, the known acute radiodermatitis and post-inflammatory hyperpigmentation, which disappeared after a while. You can still see that the not treated areas present with DSAP. However, the treated area is clear of DSAP lesions. And then further case from a patient, we can again see the post-treatment erythema and widespread DSAP lesions. And then after some time, you can see that the hyperpigmentation is fading away. And here is the last picture that we have of this patient. He had all his lesions treated in the meantime. This is really decreasing in redness, and the clinical outcome is very satisfactory. So for conclusion, I would like to say that radiotherapy with Grant's rays could be a good treatment option for patients treated with patients with DSAP. We have a very good known safety profile with radiotherapy, and our results show that the relapses are limited. However, prospective and possibly multiple center studies are needed. Thank you very much for your attention.
Thank you, Dr. Ramelet. Okay, so first question coming in. What scale are you using to assess dermatitis? I'm not sure what E5 dermatosis means.
Well, thank you for this question. At the University Hospital of Zurich, we established our own radiodermatitis scale, where E1 just is a faint redness, whereas E6 would be necrotic areas. E5 would be very dark erythematous area with hemorrhagic crust. Yes, I hope this answers your question.
Okay, thank you. Next question, why were Grant's rays of 10 kV used rather than 20 kV or 30 kV?
Well, we use this based on the assumption that it's not a malignant disease, also having in mind the histology of the DACP, which is a superficial lesion, so we don't need to apply 20 kV, which would be soft rays.
Okay, next question, what energy are you using?
You mean in gray? We use 4 to 6 gray, depends a bit on how widespread the lesions are and how fast the patients want to get the treatment done. Our own scale is that we do it 4 gray twice a week. If the patients have to leave earlier for, I don't know, what other medical reasons, then we sometimes do 6 gray at the beginning and then continue 4.
Okay, next question. Do actinic keratosis improve with Grenz rays as well?
Yes, they do. What we also do at University Hospital of Zurich, we treat with radiotherapy larger areas of actinic keratosis, field cancerization, for example, on the scalp area. We also do it with Grenz rays. And yes, they do improve.
Okay, next question. Is there any local treatment for radiodermatitis?
Well, you can use a lot of local therapies, similarly to other wounds. What we use in a lot of patients is black tea compression or gauze. So what you do is you prepare a black tea, a very strong one, and let it cool, and then use a compress on the area that was irradiated for 10 minutes or so, and then apply any other wound healing cream. I don't know what country the question comes from. What we have in Switzerland is Yellogen with hyaluronic acid, or Bepanthen is also very well-known local therapy with panthenol in it. So anything.
Okay, and final question. What is the HVL aluminum and how do you calibrate the machine?
Oh, we have to ask our physical support for that. I'm sorry, this is a bit outside of my field.
Okay, that's certainly understandable. We can circle back with the person asking this question in the future. So thank you again. Thank you so much, Dr. Remelet, for your presentation. Know that you need to get going on to another commitment. So thank you again for your support for this session. We really appreciate your involvement. With that,
thank you for having me.
Yes, it's been a pleasure. With that, I'll go ahead and transition back to our chair, Professor Doomer. The next talk will be on radiotherapy of inflammatory disorders on palms and soles.
Welcome everybody to this presentation on radiotherapy of inflammatory disorders on palms and soles. So I want to thank also my co-workers here for this and our radiology assistants, Mrs. Wiesmer and Mrs. Farrell. So here are two typical presentations of inflammatory diseases on palms and sole. On the left-hand side, the diagnosis is not trivial. You can consider psoriasis. It could be also lichen planus. It could be a chronic eczema. So the diagnosis of these conditions can be very difficult. On the right-hand side, you see these cracks in the skin. So this looks more like a hyperkeratotic chronic eczema. So this type of inflammation you can see, for example, in the context of atopic dermatitis. Though there are a number of benign diseases for which intermediate doses of radiotherapy are used, for example, Dupuytren's disease, chronic eczema, or psoriasis. And you see that in all of them, the pathology is on the surface, at least in the eczema and the psoriasis. You see that the dose that is planned for these conditions is around 5 grays up to 8 grays for psoriasis. The risk for normal tissues below that depends on the tissue associated to this, and on the palms and sole, I think the risk is quite low. And there are only a very few data available how the long-term efficacy of irradiation will behave in this patient population. So if you think about these diseases, we have to understand that in these diseases, we have an amplified conified layer, and then we have the epidermis. So in general, a penetration of 1 millimeter is fine if it's not too hyperkeratotic. And then in these situations, you might use 20 kilovoltage to have a penetration around 3 millimeters. So I show you here a picture from our old machines that we have used earlier. I like this machine because everything is so simple. So it has always a fixed combination of the voltage and the filter applied, which is, for example, aluminium for the 20 kilovolt. And also then you see here the connection with the currency and the counter for the treatment duration. I would really stress again that 12 kilovolts, 10 and 12 kilovolts, so grants rays are suitable for many of the patients, and only in cases where you have very pronounced hyperkeratosis, then 20 kilovolt might be applied. Nowadays, we use this modern treatment device that is quite easy to use and has a computer-based machine to start and to control the irradiation. You see here an example. So if you use this type of tubes, you can irradiate more or less the full hand. So this would be the setting that we are using for patients with palmoplantar inflammatory disorders. Still, we have to remember that irradiation is using a carcinogenic physical method, and therefore we have to think about the irradiation-induced risk. And based on the location, I would say that the risk is quite low. Nevertheless, I think irradiation is a treatment that should be restricted to elderly people and should be used if other options do not really manage to control the symptoms. For tinea capitis, for example, in children, there is a clear documentation that there is an excess risk of irradiation-induced skin cancers in this setting after radiotherapy. And on the skin in general, we have to consider that the carcinogenic effects of the irradiation will overlap with the effects of ultraviolet irradiation. It's estimated that the lifetime risk to develop a radiation-induced basal cell carcinoma is 0.006 if 100 square centimeters of skin are treated with a mean dose of 3 gray. So at the end, the risk is very low. And we still know that many patients are developing non-melanoma skin cancers without any irradiation. Still, if children are treated, for example, for keloids, which can also happen sometimes, long-term surveillance is advised for these individuals. Let's go into the literature. So this is a publication that has summarized the impact of irradiation therapy on chronic palmoplantar inflammatory diseases such as eczema or psoriasis. Here, low-dose irradiation was used, so the median total dose was 12 gray. There was most of the patients were treated with 0.5 gray in a fraction up to 5 gray. And this was a patient population of in different ages. Actually, the results are quite encouraging, since we see an improvement of the symptoms at the end of the irradiation and also at the last control. So many of the patients had a clear improvement as reported in this publication. Unfortunately, this publication has some shortcomings. So overall, the patient population is very heterogeneous. There are most of the patients are suffering from eczema. It's not specified which pretreatments, the type of eczema, so chronic hyperkeratotic one versus dyshidrotic whether it was in the context of atopic dermatitis, no information on the duration of the disease. There is no information on concomitant therapies. And also the recruitment period for these 28 patients was quite long, so it took over 6 years to collect them. And at the end, we have to state that there is no information about long-term effects. In the same publication, there is this table on randomized controlled trials for the irradiation therapy of palmoplantar eczemas and psoriasis. And the summary is that there is really a poor documentation of a long-term benefit using irradiation. In general, I think we can say that there is a short-term improvement, but the long-term outcome in general is not really very promising. Nevertheless, we use irradiation therapies. You see here one of our patients where part of the palm is affected by a chronic eczema, not too much hyperkeratosis, but you see inflammation and scaling. Also, the fingertips are scaling, and the patient was really disturbed. And local corticosteroids and skincare did not improve the overall system. So the patient had an irradiation with quite a low dose, 6 grays here with Grant's rays. And you see here at the control, which was 3 months after the irradiation, a clear improvement. Unfortunately, we do not know how long this patient has profited from the improvement. Here, another patient which had a lot of problems, painful inflammation of the palms and sole, and a clear improvement after Grant's therapy. You see here the total dose was 12 grays. So these were 6 sessions. Applying 1 gray per session. So at the end, these are like anecdotal cases that show that irradiation therapy can have a benefit in this patient population. Still, I want to stress that inflammatory diseases of the palms and soles need careful diagnostic workup. I think mycology is clear, patch testing should be done, atopy screening and biopsies, but be aware that the biopsy result can be also confusing because on the palms and sole, it can be very difficult to distinguish between psoriasis and eczema, for example. There are more and more powerful systemic treatments, and therefore systemic treatments might come first. These treatments are based on the precise diagnosis, so depends on the diagnostic workup. And only in chronic hand and feet inflammation, which can be in the context of eczema, psoriasis, or lichen planus, that are non-responsive to systemic treatments, and the elderly population, X-rays are considered a reasonable option. And still, I believe that the data that are available today are not sufficient, so randomized clinical trials are urgently needed, and I would really recommend to do long-term surveillance in these patients to detect any radiation-induced cancers. Actually, I don't expect too much, but it would be important to have very reliable data in this context. And with this, I thank you very much for your attention.
Thank you, Professor Doomer. First question is, what is the maximum field size on the Xstrahl machine?
With our largest tubes, we have a diameter of 10 centimeters. So this is enough for a small palm or a reasonable palm. If larger fields are necessary, then we cut lead in order to have the area that we want to irradiate.
Okay, thank you. Next question, in your experience, how long are the remission periods?
That's a very good question. So outside of clinical trials, these patients are always treated with X-rays in addition to topical treatments and sometimes systemic. I would say in general, we should expect a positive effect for 6 to 12 months. There are very few cases of long-term documented benefit.
Okay, next question. This attendee has been using radiation with psoriasis and has seen psoriasis respond quickly to radiation, but then it appears to come right back. Her question for you is, would you retreat that area again? And what would you recommend as a retreatment dose?
That's a very good question. So our internal rules, well, they are certainly also subjective, but our rules are we do up to 3 treatment cycles. For one cycle, we apply a maximum dose of 6 gray. So if you repeat this 3 times, then you come up to a total dose of 18 gray. This we consider is acceptable in patients of advanced age. However, well, the topic is open and needs additional long-term follow-up.
Okay, you spoke briefly about the keloids treatment in children. Are there clinical situations suggesting the use of X-ray therapy in children for other indications?
Well, actually, in children, keloids can really be very bad. And I remember a few youngsters. So youngster is between 8 and 12 years that had rapid relapse of typically corrections of the ears. And these are huge keloids. And these children, they also don't like to be injected. Topical treatments do not work, so they undergo another surgery. And then we know that we can reduce the risk for a relapse if we immediately irradiate after surgery, and we consider this more acceptable than doing, for example, corticosteroids injection. So these are our youngest patients, but I would really say this is only a handful over the last 10 years.
Okay, thank you. And final question, is there a dose limit for these indications?
Yes, our internal dose limit is 20 gray. I know if we are using Grenzway, we could go a little bit higher, but in general, we stick to the 20 gray limit per field.
Okay, I'm going to pose one more question because it's specific to Grenzway since that came up. This attendee observes that the Grenz is so soft that it's absorbed by the air, and that the larger the cone, the longer the tube, the target tube distance, and is wondering how you take this into effect.
Well, this is obviously correct, but we have a physical measurement and know what energy is coming if we prolong our distance. So we have 12 centimeters and 20 centimeters, and if we go for 20 centimeters, then the irradiation time is longer, and with this is compensated.
Okay, thank you so much. Now we're going to transition to your second talk, Dr. Doomer. Dr. Doomer will be speaking in his next presentation about irradiation therapy for nail disorders.
With this presentation, I would like to introduce you to the irradiation therapy for nail disorders. The nail is a very complicated anatomical structure. We have to understand that the growth of the nails is occurring in the proximal nail fold, and then the nail is over the nail bed. So, the nail is also protected by the epinuchium. So depending on the pathological process that we want to treat, we need to irradiate the nail bed, or we have to irradiate the nail fold. Let's have a look on the references that are around. So for example, in the book of Goldschmidt and Panizon, Modern Dermatologic Irradiation Therapy, there is just one short paragraph on the irradiation of the nail dose. The recommendation is that we have fractions in the range of 0.5 or 1 gray, and that we use 20 or 30 kilovolt for these type of treatments. Indications for this is, for example, psoriasis or lichen planus. So here a clinical picture. We see here these pits on the nail, Actually, these pits are occurring because there is some inflammation in the matrix and in the nail fold. Therefore, if we want to impact on that, we have to irradiate the nail fold, and it will obviously take some time until we see that the nail is growing healthy again. Here another situation. Here we have alterations in the nail bed that detach the nail from the nail bed. So here the irradiation should be for the nail bed. So this is the distal fingertip or other situations. And as here, I think here we have combinations of alterations and inflammations that are going on in the matrix and in the nail fold. So I would definitely include the nail fold during the irradiation process. But there's also a discoloration of the nail bed. Therefore, it would also make sense to irradiate the nail bed. And then this is a very severe involvement of a nail in the context of psoriasis. You notice also a reddening of the skin of the whole fingertip. And then there are these grotesque hyperkeratosis in the nail bed, but there are also inflammatory processes ongoing in the nail fold. So here again, you would irradiate both. Actually, you see that this nail is very thick, so you can do several things. You can go for a higher voltage, or you can remove the nail mechanically or chemically in order to have easier access to the nail bed. So what do we have to consider if we use irradiation therapy for benign diseases? And I think it's always important to think about irradiation-induced cancer following the exposure of those irradiations. So here we have to think about the location of the radiotherapy fields. Breast and throat are sensitive regions because of the tissues that are below and that are very sensitive to irradiation. However, we can be really quite sure that this is not a problem on the palms and soles and on the nails. So I think in general, the good news is that the nails are areas where the risk for irradiation-induced cancers is lower than in other areas. What is the standard of irradiation therapy for certain diseases? Let's start with isolated lichen planus. So this is a quite common clinical situation. Here is a review article, very recent, in the American Academy of Dermatology journal. And actually, the first choice in this setting is the injection of corticosteroids, which is actually quite difficult and painful, has to be done in local anesthesia, and is also quite demanding for the physicians. And other ones, except intralesional triamcinolone corticosteroids, intralesionally, you can also do intramuscular, and then retinoids are used orally. Actually, these recommendations do not include irradiation therapy. There is also, in 2013, there was a Cochrane collaboration-based review on interventions for nail psoriasis, and in this review, several clinical trials have been identified that have used soft X-rays in order to treat nail involvement in the context of psoriasis. I just want to show you one study that was here. So this was a clinical trial using electron beam in 8 fractions for the nail. The assessment was performed at 3, 6, and 12 months after treatments. Actually, the early assessment showed significant reductions of the manifestations of psoriasis. However, this was not true for the 1-year examination. From this data, we would conclude that irradiation therapy has an impact on the manifestations of psoriasis in the nail. However, the impact is limited. On the other hand, we have more and more powerful systemic medications, for example, guselkumab, that was investigated. And if we look at the efficacy of these new biologicals, we can see that both serine anti-TNF and guselkumab are very potent in improving the symptoms in the nail bed. So systemic therapy, I think, is our preferred option to treat the problems of psoriatic nails. Nevertheless, there are still patients who profit very nicely. So you can see here a patient that I have treated some years ago. So both of his thumbs were involved. We decided to treat one nail with a very simple scheme, 6 times 1 gray, with a voltage of 40 kilovolt. And there was a dramatic improvement, and you can see that the other side that was not irradiated stayed involved. And actually, because of that, the patient came back 12 months later and wanted the other side to have irradiated. So still, overall, the data situation is not really convincing. However, we have examples where irradiation therapy might be very helpful. So let's conclude. Historically, radiotherapy was used to treat various benign diseases, including psoriasis, lichen planus, acne, and so on. And nowadays, we have very powerful systemic treatment options that can contribute to control these local manifestations, including the nail. And still, we have to think about the low risk for irradiation-induced cancers. Therefore, in my opinion, the use of X-rays to treat inflammatory skin conditions should be the exception. So I would really use this only in patients of advanced age. However, still in some specific situation, it would make sense. And if I do this, I always inform the patient and do a careful documentation about this information. And at the end, I believe that clinical trials would be helpful to improve our knowledge when we should use these treatment options. Thank you very much for this, for your attention.
Thank you, Dr. Dummer, for your second session. Dr. Dummer, we have the first question coming in now. What is better to use, superficial X-rays or electron beams, meaning, MV?
Yeah, well, I'm definitely in favor of superficial X-rays. These X-ray devices are very simple to use. You don't need a lot of calculation. And in my personal opinion, the use of electron beams for these indications is somehow overshooting the problem. Stay with the simple machines and they do a perfect job. So don't use electron beams for that.
Okay, next question. What do you say to your patients asking about the risk of developing skin cancer and radiotherapy in the area long term?
So the first thing what I tell them that X-rays are never healthy, but there is definitely a dose effect, and there is always a question where, in which body region you are irradiating. And then I explain them that, for example, palms and soles or the nails, these are regions where we don't have radiosensitive tissues below, so not like in the breast, for example, or the thyroid glands, and that we are using very low doses. And at the end, sometimes they ask what is the alternative, and then if we go for corticosteroids, for example, we also have to say that these are immunosuppressive and have some risk. Or if we use, for example, local 5-FU, this is also causing DNA damage. Also, UV irradiation does. I always tell them there is a minimal risk, but because of the medical history, we think that this risk is justified.
Okay, thank you. Next question. What if you have a glomus tumor under the nail bed? Can radiation be used to target that if it grows and causes pain?
Well, this is the dose and the type of irradiation that we use is not suitable to be really anti-proliferative for benign tumors, or benign tumor has even also a low proliferation rate. So I think this is nothing, is not amenable to treat glomus tumors. In this situation, surgery is the treatment of choice.
Okay, next question. What dose do you recommend for psoriasis of the nail bed?
So typically we go with a fraction dose of 1 gray, and we aim to go for 6 grays. After 6 grays, we make an interruption and wait for several weeks and see whether the nail is improving. If not, then there is the option for additional 3 times 1 gray.
Okay, and final question, have you used brachytherapy in any of these scenarios?
No, we have not used this. In my hands, this is by far more complicated than the soft X-ray machines, and there we will stick to our machines.
Okay, thank you again so much for your presentations, Dr. Doomer. With that, I'd like to introduce our next speaker, Dr. Richard Schaffer, who will be speaking on radiotherapy for psoriasis.
Thank you. My name is Dr. Richard Schaffer. I'm a clinical oncologist and clinical lead for benign and skin radiotherapy for Genesis Care. I'm also the medical director of Xstrahl. Today, I'm going to talk about radiotherapy for psoriasis, a literature review. So first I'll do an introduction about psoriasis and standard treatment. We'll talk about the radiotherapy rationale and depth considerations. I'll then take you through the literature review, really in summary with the effectiveness of different sites, and then some conclusions. So psoriasis is a common chronic inflammatory skin disease. It affects approximately 2% of the population, and symptoms include itch, dryness and cracking of the skin, and pain and disfigurement of the nails. It can severely affect quality of life of patients, and 75% of patients say that they have moderate to large negative impact on their quality of life. It can also affect relationships and mental health. So the treatment depends on the severity of the disease and impact on quality of life, the presence or absence of psoriatic arthritis, and any comorbidities. And in the UK treatment guidelines, first-line treatment would be with topicals, for instance, with steroid creams or vitamin D. Second line would include phototherapy and systemic non-biological treatments such as methotrexate or cyclosporine. And third line would be with systemic biological treatments, for instance, adalimumab and infliximab. So biological treatments can be very effective for moderate to severe disease. For instance, etanercept reduces reaches PASI 75 in 49% of patients with high-dose etanercept and only 4% of patients with placebo, so clearly very effective. However, there are some issues with biological treatments, and those would include incomplete clearance or recurrence in some patients, contraindications, and also long-term use has issues in terms of expense in particular, and also various risks. So radiotherapy offers a localized approach for a localized problem, particularly in difficult to treat areas such as nails, palms, scalp, genitals, or perianal skin. There's variable use worldwide, and it's very routine in some European countries, for instance, Switzerland or Denmark, but really it's rare use at the moment in the UK, the US, and Australia. So the principle of radiotherapy is to match the depth of the radiotherapy dose with the depth of the pathogenic process. So the pathogenesis of psoriasis is in the epidermis and the dermo-epidermal junction, so around 0.1 to 0.3 millimeters depth. Radiotherapy has anti-mitotic activity in the epidermis and action on Langerhans cells, modulating dermal inflammation. So you can see that Grenz rays, which penetrate to approximately up to 0.5 millimeters, are ideal for treating psoriasis, where the pathogenesis is 0.1 to 0.3 millimeters. And superficial X-rays can go further. Superficial X-rays and electrons, which can go up to around 5 to 10 millimeters, can be used where there's thickened psoriatic nails or hyperkeratotic palmoplantar psoriasis. So we performed a literature review of radiotherapy psoriasis with a structured search in January 2021. We only looked for English articles in full text, not in textbooks, and we identified clinical reports from 1958 to 2016. The extracted data included the type of radiotherapy and dose fractionation, type of study and number of patients, and the outcomes, and the findings were narratively synthesized. The overall results, we found 11 key primary studies, 7 used Grentz rays, 2 used superficial X-rays, and 2 used electrons. The population in the studies ranged from between 3 and 67 patients, and they were virtually all adults. The follow-up was up to 4 months in most studies, although a few prospective studies had a longer follow-up. But few studies used validated outcome measures or assessment criteria. And the highest level of evidence was the 2013 Cochrane Systematic Review on Nail Psoriasis. And the punchline really is that most studies concluded that radiotherapy has a role in the treatment of patients with psoriasis, particularly in difficult to treat areas such as the scalp and hands and feet. So let's go through it in detail. Let's talk about the scalp to start with. So talking about the first study, Johansson in 1987, this was a double-blinded controlled trial, 17 patients, and they treated one side of the scalp with steroids and active radiotherapy, and the other side of the scalp with steroids and sham radiotherapy. So essentially they pretended to give radiotherapy. The radiotherapy was with Grentz rays, so very low energy X-rays. They gave a weekly dose of 4 gray, and they gave it 6 times for a total of 24 gray in 6 weeks. The outcome assessment was an observer-rated score between 0 and 5 using erythema, scaling, itching, and distribution, giving a total score of up to 20. The results, there was almost complete healing in 88% of the patients at 3 months, and a reduction in severity score from 12 pre-treatment, that was out of 20, to 7 with steroid alone, and 2.5 with steroids plus radiotherapy. And at 6 months, 53% of the patients were still healed. The next study was Lindelof in 1988, and that was a randomized trial of Grentz versus Grentz plus steroids with 37 patients. The radiotherapy was given the same way with Grentz and a total of 24 gray, and there was healing in 78% of the patients overall. There was a reduction of severity score with Grentz to 1.7 and with Grentz plus steroids to 1.6, with no significant difference in reduction in severity. And at 6 months, 31% of the patients remained healed. There was then a more recent study, which was retrospective with 36 patients, and the radiotherapy was given in a similar way, but between 4 and 6 gray and given in a more empirical way between 3 and 12 times, albeit with weekly doses. And at 6 to 8 weeks, there was a complete response of 36% and a marked response of 53%, therefore giving a complete or marked response of 89%. And at the latest follow-up, which is very variable, 8 out of 36 patients had a complete or marked response. So in summary, you can see that in the trials, that percentage healed was between 78 and 89%, if you count either complete response or good partial response as healing. And in the long term, between 22% and 53% were still healed. Now, I'm now going to go just in summary through the other signs. So if we look at hyperkeratotic eczema and psoriasis of the palms and soles, there were 2 studies. Sumila had a complete and partial response of a total of 94%, and a complete response still at 20 months, median follow-up in 36%. Fenton looked at 22 patients, and there was complete and marked response of a total of 73%, and still had 50% with complete and marked response of 4 years. In nails, the picture was quite different. You can see that there were 4 studies here, and they range between a small improvement or a complete response of 4.5% to roughly a 30% response. So not quite as good as scalp or hands and feet. And in palmoplantar pustulosis, again, not such a good response. So there was an 11% response in Ferris, no complete responses in Lindelof, and in Fenton, a marked response of 33%. They said that the improvement was sustained at 3 months. There weren't really long-term results for the other 2 studies. So in summary of the trials, in summary of the summaries, for the scalp, between 78 to 89% response to the short-term, long-term 22 to 53%, hyperkeratotic palms and soles, so eczema and psoriasis, 73 to 94%, long-term 36 to 50%. So I would say, scalp and palms and soles really do quite well. Nails between 4.5% and 30%, and palmoplantar pustulosis similar, 11 to 33%. I guess one question is why the lack of response in nails and palmoplantar pustulosis? I mean, the possibilities are perhaps not enough dose, perhaps not enough depth, actually, because a lot of the time, if you're using grain sprays, you wouldn't expect it to be treating all of the disease. It might be that actually radiotherapy is the wrong treatment, possibly. And another point is that nails, you really need follow-up for at least 6 months to allow regrowth of the whole nail to assess response properly. So in conclusion, radiotherapy is effective in psoriasis of the scalp and hands and feet, but less effective for nails and palmoplantar pustulosis. The evidence is well established, but is with low numbers of patients and unvalidated outcome measures. So radiotherapy should be considered as a third-line option for localized disease after phototherapy and or systemic non-biologicals, and before biological treatments if they're contraindicated, not tolerated, or not effective, or if they're on biologicals, if they're resistant patches, that would be another area of study. And there is clearly a need for prospective studies with validated outcome measures. Thank you.
Thank you, Dr. Schaffer. So we have a couple of questions coming in. Regarding psoriasis, I guess specifically for you as well, what do you think is better to use, superficial X-rays or electron beams?
Well, most of the studies have been done with Grentz rays, and because of the superficial nature of psoriasis, for most patients you should be able to use Grentz rays alone. There are some patients where either you've got thickened nails or hyperkeratotic disease, where you might want to use either superficial X-rays or electrons. And I have to say, I don't really think that there is a preference in terms of what's likely to be more effective. It's going to be more to do with what equipment you have available in your clinic and also the logistics. I think, as Professor Dummer said, using a superficial machine is going to be much easier in terms of patient flow and so on. But if you only have LINAC-based treatment and you want to deliver a treatment that gives more depth than Grentz rays, then electrons, I think, would be a reasonable treatment as well.
Okay, next question. The attendee is wondering about depth and dose for nails. Comments that he treated a patient with nail psoriasis, all 5 fingers with brachytherapy. It was 21 gray over 12 fractions with a complete response. What are your thoughts?
So I think, the first thing to say is that because of the lack of penetration of Grentz, which is a good thing, you tend to get much less toxicity than you would with a more penetrating type of radiation, such as superficial or electron. So actually, the rule of thumb is that you can use any dose that you can use with Grentz. You could probably only use half with superficial or electrons. So I think it would be reasonable to say that you would certainly use a lower dose. Now, the studies I showed in my literature review tend to use quite a high dose of 4 to 6 gray. And I think that probably mainly reflects that the treatments were given once a week. And so as a weekly dose, that's reasonable. But, these days we would tend to probably give it more like 2 or 3 times a week and give a lower dose of a fraction. And certainly, as Professor Durma said, they tend to give more around the 1 to 2 gray sort of mark. So I think, to me, that seems like a very reasonable dose.
Okay, next question. What are the considerations of the risk of Grenz rays compared to phototherapy and systemic treatments? Have you seen any studies on this or recommendations?
Well, I'm a radiation specialist, and I'm afraid I don't have an expertise in dermatological treatments apart from that. I think they're entirely different treatments. Of course, thinking specifically about phototherapy and radiotherapy, of course, they both have a small risk of radiation-induced carcinoma. And so it's interesting that, in many countries, people very much are accepting of the risk of phototherapy, whereas people are worried about the risk of X-rays. I think we have to be very cautious with both those things. And of course, there is a small risk of malignancy also with systemic treatments, but I don't know of any comparative studies.
Okay, thank you so much, Dr. Schaffer. That was our final question. I'd like to introduce our next speaker. Our final presenter of the day is Dr. Rei Ogawa. Today's talk from Dr. Ogawa will be on radiation therapy for keloid scars, the Japanese combined surgery plus radiotherapy experience.
Okay, so thank you for joining webinar. This is Rei Ogawa from Tokyo, Japan. I'd like to talk about radiotherapy for keloids. So I have organized scar and keloid specialized clinics since 2006. Now new patients of number is 2,000 in a year. So this is keloids, sometimes caused by piercing, injury, burn, and surgery. And this is hypertrophic scars. Actually, inflammation of hypertrophic scar is smaller than keloid. So this is histopathology of hypertrophic scar tissues. Inflammation can be found in the reticular dermis. Also, this is keloid tissue. Also epidermis and papillary layer of dermis, the inflammation is very limited. And mainly, inflammation can be found reticular dermis. So it is suggested that hypertrophic scars keloids are inflammation of dermis, reticular dermis. Actually, the difference about hypertrophic scars keloids are difference of strength and duration of inflammation of the dermis. So important things is that there are favorite sites of keloids. And these sites are frequently stretched or subjected to high stretching tension. So this is computer simulation of skin stretch. When we stretch skin horizontally, the high tension area lies on the edge of keloid because stiffness of keloid is hard, so cannot release tension. So adjacent skin, the tension increase. So please compare to the clinical appearance. The inflammatory region is completely matched with high tension area. So high tension is an important risk factor of keloid. So for clinical meaning, it is important to release tension. So sometimes we use Z+D to release tension. So immediately after surgery, zigzag line wound is produced. And 3 months after surgery, please look at horizontal wound. Inflammation has already gone. And 6 months after surgery, 1 year after surgery, tension released and inflammation decreased. So actually, keloid looks like burning house, strong inflammation. And repeating stretching looks like adding fuel to the fire. So our treatment modalities are, there are many modalities, from mild treatment to strong treatment, including radiation. So sometimes such kind of strongly burning house should be treated by operation and radiotherapy. And the inflammation, once decreased, we should change to the mild modalities. So actually, the keloid and hypertrophic scar is an inflammation, not tumor. So steroid works. So target should be reticular dermis, deep layer of the dermis. And the steroid is injected, inflammation decrease little by little. So the size of keloid is small, we can treat by steroid injection. And especially in Japan, we can use very strong steroid tape. This is very effective treatment. Every day patients have to change the tape. But for children, the weak steroid tape would be fine because skin thickness is not so thick. But adult patients, the strong eclaplaster, the diprodone propionate should be a first choice. And such kind of minor keloids can be treated by steroid tape only. I'd like to move to the talk about radiation monotherapy. This is very strong modality to decrease inflammation of keloids. We have used mainly beta ray, electron beam, but sometimes we have used brachytherapy, gamma ray. Actually, beta ray is easy to adjust the depths, and after penetrating dermis, the immediately decrease the dose, so it is clearly safe. So beta ray is a primary choice for keloid in Japan, and we have used protector and bolus to adjust thickness. And sometimes for incisional wound, we have used external brachytherapy. This is primary radiotherapy. We have used 25 gray 5 fraction for 5 days, but please look at the clinical cases. After radiation, color was firstly changed. This means number of blood vessels decrease, and inflammation decrease, and the scar height decrease, and maturation is accelerated. 18 months after treatment, it became completely mature scar. This is also inflammation completely decreased and that changed to mature scars. This is also peripheral area. The high tension area, inflammation is strong, so treated by radiotherapy, just peripheral area. This is another case. But the thicker keloids cannot be treated by radiation monotherapy because the radiation dose should be increased. So in that case, postoperative radiotherapy would be better. So before 2002, we have used 15 gray unified protocol. But total recurrence rate is around 30%. This is an acceptable result. So we have changed since 2003. And we have optimized the customized dose protocol, and the high tension area was treated by increased dose, 20 gray, and the yellow was decreased to 10 gray. And in the result, the total recurrence rate decreased to the 12%. And this is the most recent protocol. We have changed and optimized little by little the protocol. And now, anterior chest wall scapular upper arm high tension area is treated by 18 gray 3 fraction 3 days. And the yellow is treated by 8 gray 1 fraction 1 day. And other regions are treated by 15 gray 2 fraction 2 days. For example, if the surgery is performed Wednesday, the radiation started Thursday. And for example, 3 fraction 3 days in case the radiation is performed Thursday, Friday, and Monday. So actually, we have considered biological effective dose. In case of keloid, alpha beta seems to be 10, and there is an evidence that the risk of calciogenesis is low when we set BD to less than 30 gray. So BD 30 gray equal 20 gray 4 fraction 4 days and 18 gray 3 fraction 3 days. So high tension area was treated by 18 gray 3 fraction 3 days in recent years. And this is questionnaire against radiation oncologist. So actually the attitude of radiation oncologist to treat keloid is different by regions. For example, there are a big difference between Europe and North America. So Japan, North America, 90% of radiation oncologists accept keloid treatment using radiotherapy, but just 50% of European oncologists accept the keloid treatment using radiotherapy. Also, we have discussed the risk of side effect, risk and the side effect of radiotherapy for keloids. In conclusion, we have concluded we should avoid it in children and infants, and we should avoid it in thyroid and mammary glands area. So I'd like to share my cases. The simple suture and radiotherapy. They remove everything and tension is removed and radiotherapy was performed. This is chest wall surgery and remove everything and sutured and radiotherapy. And sometimes we have used W-plasty and Z-plasty to release tension. Tension is released and radiotherapy was performed. 18 months after surgery, 2 years after surgery, similar case. And this case was also surgical keloid, surgical scar. Keloids are removed everything and Z-plasty is performed. And 18 months after surgery. And this is also scapular keloids, 18 months after surgery and radiotherapy. And such kind of sick keloids are a good indication of surgery and postoperative radiotherapy. And this is VCZ vaccination keloid. Tension is released and radiotherapy was performed. This is trauma keloids. Remove everything and Z-plasty and radiotherapy. 2 years after surgery. Long linear incision should be segmented. And sometimes local flap has been used for huge keloids. This is keloid started from folliculitis, not burn cases. Folliculitis keloids. The contractured area is replaced by skin flap, and the margin is irradiated. And you can realize the range of motion was improved completely. And this is a elbow joint and the chest wall. This is another case. This is the keloids, severe keloids with multiple diabetic ulcers. So now we can conclude keloids and hypertrophic scars can now be cured completely, because such kind of severe cases, they remove everything and the flap is raised and release tension and the radiotherapy was performed. So please look at this, range of motion improved a lot. And sometimes core excision method was used for specific region, including cartilage part of auricle. The just core is excised because keloid is an inflammation of reticular dermis, so just reticular dermis is removed, and suture softly and radiotherapy was performed. So we don't need to cut ear, just the core is excised and skin flap is turned back to the backside and sutured, and radiotherapy was performed. So there are no recurrence 18 months after surgery. And the wedge excision can be used for earlobe. Such kind of big piercing keloid, cut and suture and radiotherapy. This case was treated by postoperative radiation 10 grade to fraction 2 days. This is another case. So now in Japan, main treatment for scars is a control of tension and inflammation. So primary choice is steroid tape and plaster. If it doesn't work, surgery and radiotherapy is the second choice. So we should know even severe keloids can now be cured completely, mainly using surgery, radiation, and steroid tape plaster. And on a case-by-case basis, silicone gel, seeds, tape, steroid injection, lasers, ointment, and makeup therapy are selected. So we have a lot of cases. So we always welcome visitors from all over the world. So if you are interested in, please stop by Tokyo and let's discuss about keloid treatment. Thank you very much.
Thank you, Dr. Ogawa. Dr. Ogawa recorded his session previously from Japan and is not available today for Q&A. On behalf of Xstrahl, I'd like to make a huge appreciation for Dr. Doomer, who served as today's session chair, as well as all of our speakers for today's event, Dr. Schaffer, Dr. Remelet, and of course, Dr. Ogawa. On behalf of Xstrahl, I'd like to thank you for your attention. I hope that you have a fantastic weekend. And with that, I will conclude today's event.